So I'm going to kind of bring you through a bit of background about the primary care network. I've done this talk before in an hour and a half presentation. In an hour presentation, I've been told today I only have 15 minutes. So I'm going to talk really, really fast. And I try to shorten it down, trying to give people some background. I know a lot of you have seen this, but a lot of you haven't. So let's see how the slides work. So why are we here? Really, we felt, most of you feel, that primary care needs a voice. They're structured locally to communicate with agencies, with each other, and to create a unified voice if we want to look at pushing some change within the healthcare system. And we see ourselves have a different role. We know that the OMA is out there representing family physicians. We know that the OCFP is out there representing family physicians. And we feel this can be a symbiotic group to work together with these two groups in realms that cross-cover, but also in parts that don't. That as primary care practitioners, we have issues, ground roots issues, that may be local issues or regional issues that we can bring to the table to try and make change. So that's one of the reasons why this has come about. We established the primary care network formally in 2012 in September. And we sort of said this was our initial purpose. We want to connect primary caregivers in the Southwest and essentially be the go-to group. So if a regional program wants to discuss things that they are proposing and how to affect family practice, the goal was to get them to come to us before a program is launched, or even in a planning stage to get primary care input. And as we found over the 2 years, that's what started to happen. People started to recognize we were out there, and rather than saying, this is what we've launched, what do you think? They would come to us and say, this is what we're thinking of launching, what do you think? And say, this is what we're thinking of doing, can you come to talk to us before we even implement? So we kind of got to an early step, which became, for us, we felt valued, that our opinion was being listened to, and in turn, hopefully made some change in the system in a positive manner. As Rod mentioned, we had some funding partners. So in the first year, the OMA, the LIN, and the London Regional Cancer Clinic became our partners. And in the year 2, we had the OMA, CCAC, and the LIN, with the Regional Cancer Clinic and the Diabetes Regional Coordination Center, which is not in existence anymore, but at that time we're providing in-kind funding and support of minute-taking, helping us organize meetings, just the administrative support that a group like this really needed. So this is what it looked like in year 1. Rob introduced some of the names, but our goal was to have regional representation from across different areas, rural, urban, different types of practice, FIT, FOs, FINs, FIGs, whatever F word you want to use. Also academic practices, so we wanted to, and we pretty much were able to achieve that. If you look at the names, you hopefully know some of these people. There was a little bit larger group in London, but when we look at the representation, there was probably around 800, 850 family doctors and nurse practitioners in the LIN, and so and about 300 or so in the London area. We don't have the exact numbers, but we're estimating. So we look at being a larger group in London, it kind of has some representation. So we developed what we called an engagement strategy. Essentially, it sounds very simple, but the idea is creating a network of networks. So if you were a member of the primary care network, we wanted you to reach out and engage another group of individuals. So it became sort of this social media kind of concept, but hopefully a little bit more of true tapping on the shoulders, emailing, and even talking in person to your group. We also tried to create an email network. So this is just an example of the first couple of years of all the different agencies that came to us. I'm going to point out something that I've done here on purpose, is I have these arrows as two-way arrows. And I've done this on purpose to represent that this is dialogue rather than this is what's going on in preaching or just giving education. We had dialogue that was two-way, interactive, listening, and working together to change the system. So as you can see, we had Cancer Clinic, Palliative Care, Partnering for Quality, Health Quality Ontario, CCAC, a number of their programs, Stroke Network, Spine Center, etc. And there was more. This is just an example of what we've done. So one of the things we did as a group is we sort of said as we got together, is, along with us being this regional group that people could come to, we want to do some work ourselves. And so we had 2 or 3 sort of conversations with the network to say, okay, what do you want to do? And some recurring themes came, and we were able to sort of classify them under some these things of what we could do. So one of them was just related to access to care. And at that time, there was a large percentage of diabetics that were unattached to family doctors. So these are complex patients that were essentially orphaned. They did not have a family doctor. So we felt this is something that maybe as an initiative we could do to work on to see if we could get some family doctors to take on these patients. So in February 2012, actually, those numbers are wrong. It's February 2013. I just realized I got the numbers a little wrong. There was 197 diabetic patients on the Healthcare Connect's roster. By the end of September 2013, there was 2. Looks like a great success. We'd like to take credit for all of it. There are a lot of things that were going on at the time, but we know that we had some part in that. It's hard to measure the true outcome of what we did, but it was really interesting to see the significance of the change. Looking again at access to care. So this seemed to be a recurring theme that came up. Improving the basically the physician-specialist consultation process. How we communicate between specialists, whether it be through a referral letter, through a discharge summary, etc. And I know probably every second study group meeting I would go to, one of my colleagues would always be complaining about something. It's, again, a recurring theme. So we said, let's see what we can do about that. And at the time, we had some links with the cancer program, and we were introducing the high-risk colonoscopy program. So resurrecting the program for those high-risk patients, because that was here for a while in London and then got stopped and then restarted. And one of the things we found out is right away they wanted their form to fill out. And we were having this discussion how we're getting more and more electronic and we want to generate referrals via our electronic medical record. So we had a bit of a roundabout in, and very quickly we had some conversations with the colorectal cancer program. And they said, okay, we'll take a look, and we'll take a week, we'll take a look at these referrals as they come in their electronic base, and see if we're getting the information when they want. And within the week they said, this is actually fine, we'll take any referral. Quick win. But it wasn't until we opened up the conversation and they recognized it, because all they were looking for is they wanted to know if they had family history, and they wanted to know if they were on anticoagulant. And our EMRs are telling us that. So they were very happy with that. Looking at just sort of continuous quality improvement, something called advanced access, and hopefully all of you are practicing. But a concept that's been going out there, Health Quality Ontario had been teaching. And we said, rather than us going out there and trying to teach it, let's sort of step on to the HQO bandwagon. They're out there trying to get individuals involved in their ways. Let's see what we can do with that. So we said, let's see if we can increase the number of people in our region doing it. And in that wave 4, we had the largest number of participants across the whole of Ontario in our LIN participating in HQO's Advanced Access Initiative. One of the things we thought about, let's see if we can develop a quick win initiative. And so one of the thoughts was looking at abdominal aortic aneurysm screening. And this has been a bit of a slow process, and John Thomas is going to talk to us a little bit about that later today, where that has gone to. But the idea came up from this work at the Primary Care Network, and I won't take his thunder and let him tell us how that's been working. But it allowed us to get some collaborative work with the Partnering for Quality group, which again we'll talk about later. And then in turn, John and I were asked to be participants on the Primary Care Working Group for the Vascular Strategy of Ontario, which we both are still sitting on right now, and are actively involved. So it's led to some other interesting opportunities. Educational sessions. Well, we did a few, but one of them was we did one with the nurse practitioners and primary care providers in general. Got together with the Regional Cancer Program, did a big breast cancer education session. This was done very well using telehealth sites at rural areas. We also did one with the Spine Center too, which I did not mention. So let's talk about the evolution, where we're going. And this is the evolution of the modern computer junkie. So, getting short-sighted and punch back. So, really what we want to do is build and expand on our network and network structures. We want to sort of look at the region and create local primary care networks within each sub-region of the LIN. Best explained by the picture. And so when we look at our diagram here, I'm going to kind of stand to the side here, is in the center we have what we're going to be calling the Primary Care Network Executive. And that executive would constitute the primary care LIN leads, myself, Rob, John, and Scott. along with the cancer care lead, Janice, being on there. Our thought here is that since we are paid members of the LIN, we want to be involved, but we want to ensure that there's not a sense of influence. We would also be a non-voting members. We would have nurse practitioner representation, representative from various types of practices, local primary care network representatives. So this would be representatives from each of the local networks across the region, which are the orange boxes. So when we look at, for example, the orange boxes, that would be a local network. So let's go down to the bottom. We see Huron-Perth Primary Care Network, which is the first one that's been established. We would have a chair that would be elected to sort of help coordinate and run. We would have representation from their region. And we would hope that the chair and a representative would sit on the executive. So similar across the other regions. We have had a meeting in Elgin now in early March. And I know that some of the individuals who were at the Elgin meeting are here. We didn't introduce you because I know you haven't made a formal commitment. But I'm hoping to draft you today. But no, the reality is I'm hoping because you're here, you're interested. And I know there's others that haven't been able to make it here. We've also had a meeting towards the end of March with the London Middlesex group, and we had about 20 people out that, which I was very happy with. And so again, I know that some of them are here, some of them aren't able to make it here. And we're going to try and expand on those. We're working on some conversations now with Oxford and Huron-Perth to start getting together a specific meeting group in those areas. And I know there's some people from Oxford and Huron-Perth area here. I mean, not Huron-Perth, I mean from the Grey Bruce area. When we see on the outside boxes, we have HealthLinks. And we thought it's important to recognize how HealthLinks has a family medicine presence and how this could be linked to the primary care network. So that the HealthLinks, and right now we know that here in Perth, HealthLinks is running. London HealthLinks is into their final stages of waiting for approval for business planning, the London Middlesex HealthLink. And the other 3 HealthLinks are in the process of being developed. But the idea is that there would be a family physician potentially representing the HealthLink that could also sit on the local primary care network to be involved intimately with that. So that's kind of the way we've structured this. The structure could change, but I think it's a fairly good template. We've developed a terms of reference, which as we get together with groups, we can kind of elaborate more. But the idea is just to get people to understand, how these groups will work. We feel that maybe there should be at least 3 meetings minimum per year with each local health link, or pardon me, local health network. That doesn't mean it has to be only 3. Already I know when we had a conversation in Elgin, there was a suggestion that maybe that's not enough. We're happy with that. We're hoping that we want these groups to be locally run from the grassroots. And that's the underlying goal of this. I'll feed up to the executive network group, but also to feed back from the executive network group to lead the work plan which we're going to develop today through these smaller local networks. So that is where we're evolving, and we will kind of see where the day goes. Any questions regarding that? Okay. I was clear. All right.
Good job, Gord. Thank you very much. I'm just going to set up the day here, and then we'll get into it. So, first off, we want participation, so feel free to raise your hand or interrupt. It's always okay if you'd like that. This slide represents the numbers that we started to use to define where the Southwest Primary Care Network is going to go. This came out of the meeting in September. This can totally change after today. But I wanted to touch on these because I think it'll help set the context in addition to what Gord said. The 15,000 less refers to the LIN Big Dot measure for the attempted reduction in emergency room visits. So the LIN is hoping, and it's through a number of initiatives, to reduce the emergency room visits in our LIN by 15,000. Now, another way of saying that is if every physician's practice in our LIN were to avoid 2 emergency room visits per month, then that number would be met per year. So, and that's not that much. And if we had functional health links right now, wrapping care around the high needs patients, I think that would be met 4 times over. If everyone in the LIN did advanced access scheduling, that would be met 4 times over. So it's actually not that hard with a little bit of primary care quality improvement initiative. The second one is 380, and that number refers to the number of unattached, complex, vulnerable patients in our LHIN. So Healthcare Connect identifies through some process the number of, the unattached patients who are complex vulnerable. Then there's a whole group of people who are unattached. And Gord mentioned that we had tried to roster diabetic patients, and so the Southwest Primary Care Network thought we should move that out to all of the unattached complex vulnerable patients. And speak more to that in just a second. But right now we have 380, that's actually as of August. We learned from the Here in Perth Health Link that a large part of that number comes from a practice physician who retired in Stratford. So the number's very fluid, but I'll come back to that in a second. And then the third number, 65 to 100. So Gord and I figure that we have about 65 primary care leaders, nurse practitioners and physicians. And I just want to qualify that right away. I know in the room we have a lot of people who aren't physicians and nurse practitioners. The day is for everybody. We want everybody's input today. Frequently I'm going to speak to the nurse practitioner physician thing because we're trying to structure that group. But today everybody's involved, and I don't want anybody to feel left out because I mentioned physicians and nurse practitioners. We think in the LHIN there's, the literature suggests that 13% of physicians are change agents. Those are the group we're going for. The physicians who are keen to make quality improvements, keen to drive change, keen to lead it. A lot of guys aren't, and that's okay. There's a big bundle of people that rather just watch things, and as stuff comes out and it looks like it's a good idea, then we do it. That's great. But there are about 13% of physicians who are really interested, I'm sure it's the same with nurse practitioners, who are really interested in leading change. Those are the groups we're after. If we have about 800 docs in our LHIN, we need 13%, it's about 100. So we're trying to identify and engage those 100 people in the structure that Gord drew there. In this room, today we have around 50 physicians. We have another 8 or so, 10 nurse practitioners. So actually we're pretty close to getting the 65. And that was our guess, Gord and I, that we could probably get 65 people in a room and to drive quality change. Our goal is to get that up to 100. Now that was the goal. So you guys may have something completely different, that's okay. But to frame the day, that was where we were going. I think it's actually going to happen, and I'm really pleased about that. Just to come back to that Healthcare Connect thing for a second, I would like to introduce Anna and Chris at the back on the left. Can you guys wave? This is the challenge for the day. So Anna and Chris are our Healthcare Connect contacts, and it is my hope that over the course of the day, every practice in this room will agree to take one complex vulnerable patient. So Anna and Chris, you can write my name down now. Dr. Rob Ennis, listenable. Gord?
Yes.
You can write. You can write Dr. Gord Schacter's name down now from London.
Yeah, right.
So there, we have 2 people, and I'll tell you now, you're not going to get someone who's looking for narcotics, and you won't have them phoning you again and again every day bugging you to take more. This is a process that is easy. So you let them know, you need to give them your phone number. If you represent a practice as an executive director, talk to one of your docs today. I'd like everybody to go back there and get your practice to take 1 patient. So that by the end of today, I'm hoping 25 of those 380 complex vulnerable patients will be rostered, which is somewhere between 5 and 10% of the total thing. So that's sort of how easy it is sometimes to do this. I'm going to call that a quick win. So we're going to come back to you through the day and say, this is how many Anna and Chris have marked off on the sheet, so we'll keep going down. Okay, the logistics of the day. On your tables, you'll have yellow, or the multicolored, stickies. Multicolored stickies. At any point through the day, as you think of an idea that would be a good thing for us to work on as a group next year, that is starting, this is actually our year end has changed. You just mentioned that we used to have a September to September, now we're going April to April, so this is the first meeting of this year's group. As you think of something, anything that you would like to have on our work plan, then we would ask you to write it down on the sticker, and then at the appropriate break, put it up on one of those boards. There are 3 boards, well, and a blank one, and I'll explain that. So try and put it on the right board. If you put it on the wrong board, it's no big deal. So don't fuss too much about that. But what we're trying to do is get you to think a little bit about how likely it is that your initiative is actually something that we could affect change on. So we have it divided up into 4 things. One is quick win, which is the yellow one at the back. So this is something that's fairly easy to do and has a high impact. So everybody in the room taking 1 patient today, I would classify that as a quick win. We can do that, high impact, helps a lot of people. If you think yours is like a quick win, something that's fairly easy to do and high impact, and put it on the board that says quick win. Low-hanging fruit is something that's fairly easy to do, but not quite as high impact. So for instance, putting together a group of docs to have meetings, that might not be that hard to do, but it doesn't necessarily impact care for the patient. So, you know, I know this is hard to think about, but that would go on the low-hanging fruit. And then major projects are fairly hard, but could have a high impact. And here I'm thinking of something like fixing the GP to specialist referral system. That's a major problem in our system right now, but it would take a lot of work, we think, to fix it. I don't think that's something we can do at the end of the day, and it's a provincial issue. So that would go in the long-term strategic plan. And those are all good. We're not biased against them, but we have to kind of think that way in terms of developing a work plan. And then there's the hard slogs, which are very hard and have low impact. That goes on the board with no name, and we won't look at that board at the end of the day. So if you think it's something that's really hard to do and it's going to take an awful lot of work and it probably won't get done, put it on that board and we'll ignore it. And then at the end of the day, we have a panel discussion, and at that point there'll be an opportunity to place your 3 dots. So everybody has 3 dots, no sharing, and you can vote for the ones you think should be on the top 10 list. So you pick your top 3 basically. We count up all the dots. We'll try and kind of talk about them a little bit through the day so people know where we're going. We're going to have the organizations represented on the panel to give their input into how they think the dots are stacking up. And at the end of the day, we'll be able to basically define the top 10 things, and we'll take that back to the executive, pick 5, and by the middle of June, we will report on which ones we've chosen and what the work plan says for the coming year. There it goes.